I think the main thing I'm going to try to do today is to keep this really as simple as I can. There's a reasonably systematic and structured way to approach the outflow tracts, and that's what I'm going to describe to you today. And then I'm going to move on to one or two things as to what's new, one or two newer things, and then we're going to go straight on to live scanning. I apologize in advance. I've got quite a short-term flight, so if I leave before the very end of the session, it's because the traffic's terrible to the airport, so apologies for that, but that's the reality. First of all, the starting point for all of our examinations is really going to be the four-chamber view, and I'm not going to be talking about that or situs because I don't have time. But this is the key view for starting because you will have external reference points. It's the only view with external reference points of a single rib around the fetal thorax, and you'll be familiar with the symmetry of views, the equal size of the left and right hearts. And here's a sort of starting point of a normal four-chamber view. So if you get lost in the outflow tracts, the first place to go back to is the four-chamber view, and then start to adjust from there. When you look at the outflow tracts, the next thing we're going to see is that as you come up, you will begin to see the aortic valve and the aortic root. And as it leaves the heart, it starts centrally and heads towards the baby's right shoulder. Importantly, you can see that you lose the tricuspid valve because it's below the plane of insonation. So this outflow tract view cannot substitute for a proper view of the four chambers. You're now above the view of the tricuspid valve. So you can see now the tricuspid valve is below the plane, and you can see that the left ventricle, which should be completely committed to the aorta. How do we know this is an aorta? Well, you know it from its branching pattern, and in contrast to the pulmonary artery, there is no early branching of the aorta. It heads towards the right shoulder and gives rise to the head and neck vessels, and there is no early branching. You should always be checking for this line of continuity between the septum and the anterior wall of the aorta. You will also note there's continuity between the anterior mitral valve leaflet and the posterior wall of the aorta. So the aorta is completely committed to the left ventricle. And in practice, this is essentially what we're doing. You can see we've just moved very slightly from a four-chamber view, angling up towards the baby's head. This is a very fine movement. It's a fine pencil movement, not an orthopedic movement, and it is to bring in the outflow tract. And you can see very nicely the continuity, again, as I've mentioned, between the mitral valve and posterior wall, and the septum and the anterior wall of the left ventricular outflow tract, and the direction towards the fetus's right shoulder. It shouldn't matter. Once you've orientated what is left and right and got your four-chamber view, it shouldn't matter too much to you which exact fetal eye you're seeing the left ventricular outflow tract in. And you should become familiar with this outflow from the left ventricle in any of the fetal projections so that you're not fazed by any way in which the baby's lying. All of these have normal left ventricular outflow tracts. When things go wrong, the only key thing to remember is when things are right, but you can actually see in the still image that you can now see that there is a break in the continuity between the septum and the anterior wall of the aorta, and the aorta is now overriding a ventricular septal defect. Now, you can't say exactly what this lesion is, but you can say that it's abnormal. And if you move forward here and look at this, it's another older clip, but this is the key point. There is a break in the continuity, and you're seeing that the septum is more or less pointing at the central of the aortic valve. On sweeping further up, this is the cut which you're obtaining into the right ventricular outflow tract, which essentially goes antero-posterior and divides early. And you will usually see the right pulmonary artery and the continuity into the duct. Sometimes seeing the left pulmonary artery is a little bit more difficult. And the pattern you're looking for is this lining up of vessels from the SVC to the aorta and the pulmonary artery in ascending order of size, and usually with the pulmonary artery very slightly larger than the aorta, but not a marked difference. And that's simply confirming what I've said. The AP orientation, the early branching, and pretty similar size of the aorta and pulmonary artery. The pulmonary valve you should see as thin and mobile. And the way to look at this is to say, when the heart contracts, do I see the valve disappear? So does the valve disappear completely in systole? So this is a normal outflow tract you're seeing on the left here, and a similar view on color on the right as we look. The color helps you to see the bifurcation of the pulmonary artery, and you can see this lining up of the SVC, ascending aorta, pulmonary artery, and that pulmonary valve disappearing during ventricular contraction. Laminar flow across into the pulmonary valve and antegrade flow from the pulmonary artery down into the arterial duct to the descending aorta. When things go wrong, this is a bit like the one we saw earlier. Here you see aortic override. But the right ventricular outflow tract now, you see the aorta is now bigger than the PA, which is wrong. And you are no longer seeing the pulmonary valve disappearing during systole. So it's constant throughout the cardiac cycle. And it's indicating to you that the pulmonary valve is stenotic. So this is typical of tetralogy of Fallot. The arteries are in their correct relationship, but the PA is smaller, the aorta is overriding. And again, if you take a systematic approach, you can see as you sweep up here, the first vessel, rather than going with no branching to the right shoulder, the first vessel branches early and ducts back towards the spine. And the second vessel from the RV is more superior and gives no branching and continues into the aortic arch. So this is typical of transposition of the great arteries. Equally, again, you don't see the normal three-vessel view, which we'll come and discuss later on. So three-vessel trachea view is moving slightly higher, and this is what you're cutting, essentially, are the views across these three vessels at a higher level with the transverse aortic arch, pulmonary artery leading into the duct. Usually you are cutting slightly above the level of the PA branching. So in this projection, you usually don't see the pulmonary artery branching because you're slightly higher than the plane of the pulmonary arteries. And this is probably the best view for gauging the relative size of the aorta and pulmonary artery for things like suspicion of coarctation or whatever, to look at these two vessels. And you should see the flow both going in the same direction, antegrade in the vessels towards the descending aorta. And here's the sort of typical shot that we'll see, where we're seeing the pulmonary artery straight back, the transverse aortic arch, the SVC, and that you can see the trachea here is outside of the V made by the aorta and the arterial duct. So the trachea is not between any of the vessels, it's outside both of those vessels. And in practice, what we're generally doing is a sweep. So you're looking from the right ventricular outflow tract AP and sweeping up into the three-vessel trachea view. Trachea is just in here. This fetus also has an incidental left superior vena cava. So rather than having a three-vessel view, you have a four-vessel view with a small left SVC in this particular case. But it's an excellent view for looking for vascular rings and for the relative size of these vessels. So we'll be measuring things like the distal aortic arch to gauge for coarctation, for example. And again, you can see these valves disappearing in systole in the normal way and laminar antegrade flow in both the aorta and duct down towards the descending aorta. You can use the sagittal views, and some recommendations include the sagittal views. This gives you more of appearance of the geometry of these vessels. But importantly, I'm not going to dwell too much on that other than if we can get it in the live scan. Here's the ductal arch anteriorly going down through the duct, left PA underneath, and the much more tight wound aortic arch giving rise to the head and neck vessels. Nice for geometry, but note that these are in different planes. So if you're using the sagittal approach, you can't see the aortic and ductal arches in the same plane. And so comparing the relative size is a bit more tricky than it is if you're using the transverse cuts, which is why many groups prefer to use the transverse cuts, at least as far as screening is concerned. If you want to look at sizing of vessels, certainly from our group, we've just published a series of over 7,000 cases of prospectively acquired normal sizes, and you can refer to this from last year. So let's look at things which are different. This is looking up towards the 3-vessel trachea view. You can see the pulmonary artery bifurcating and the duct here to the left of the trachea. But in this example, the aorta continues to the right of the trachea. So in this situation, the trachea is between the right aortic arch and the pulmonary artery and left arterial duct, giving the potential for a vascular ring. So this is typical of a right aortic arch. You'll see that there is a vessel crossing anterior to the trachea, and this is usually the left brachiocephalic artery, but you need to be very sure that you're not dealing with a double aortic arch, with a right-sided and a left-sided aortic arch, and we'll have a look at that in a second, just as an example. So this is the typical anatomy that we're seeing, with the right arch, left duct, and the structures between. Double aortic arch, this is where you get 4 vessels, right arch, duct, and the trachea is between the right and left arches. So this is where it gets a little bit more tricky, and you need to be very clear about what your normal views are before you pick out something which is abnormal. But since these views have been introduced, we're inundated with arch abnormalities of this type. And here you can see the appearance of a double aortic arch. We like to say this looks like a bit like a Z or an S, like a Zorro sign, with right arch, left duct. That's the usual pattern. Something you may have seen, and we use quite a lot now, this is the recently described from our unit 3D motion-corrected fetal cardiac MRI. So this is a double arch, reconstructed from fetal life, showing both the position of the trachea and the aortic arches. Clearly that's not ultrasound, but it's of interest. Don't forget, I know there was a talk about SMI early on. We use a lot of this technique in early gestation. So you can see at the top left here, looking at the 4 chambers pulmonary veins in the early gestation heart, and you can track through the outflow tracts in early gestation really very nicely with this technique. To 4 chambers, looking at left ventricular outflow tract, right ventricular outflow tract, and transverse aortic arch. They light up beautifully in the first trimester. And this is an example at the bottom here from our recent publication on this subject, showing the right arch, and left-sided duct. So this is a double aortic arch at 14 weeks. Finally, final slide is something, again, we're looking at just to kind of whet your appetites. If you're scanning, this is machine learning. It's not stopping and acquiring, it's automatically recognizing the planes. So these boxes are appearing, there's no human involved, this is just being recognized by the system. So we now have a prototype system that will produce all of the views automatically from scanning and produce a report of the key views without really the operator doing anything other than scanning through the region of interest. It's not quite that simple, but it's something for the future. Finally, please, you've got a few flyers around. We are having a 2-day course in early November if anyone fancies a trip to London, even after Brexit. And if you want to see more, our book is around at the Congress, so please have a look. So I'm going to move right along now to do the live scanning, and we can go on from there. So baby's moved around a little bit from when we started before, but let's start at the very beginning here and see what we can see here. We've clearly got the fetal stomach here, which is sitting over here to the left, descending aorta, 4-chamber view. Baby's just moving a little bit spine up. And let's magnify this up and see how we can do. I'll see if I can find a better view into this baby's heart before we get going. That's probably a bit better. Okay, so So again, in the standard orientation of 4 chambers here, nearest the spine, LA, RA, pulmonary veins, left ventricle, right ventricle. And so having found the true 4-chamber view, I'm angling very slightly up, and we're just beginning to bring in the left ventricular outflow tract here. As a general rule, if you see the spine at either 9 o'clock or 3 o'clock, it's going to be bad news for the LVOT, but good news for the RVOT. So here, I'm going to try and bring in the LVOT here. I'm going to try and accentuate that with some color, but please don't rely on color alone for this. We're now seeing, as I angle up, there is the color flow, color jet going towards the baby's right shoulder. I'm going to switch to the twin view here so we can see both at the same time, but not so brilliantly seen. You can probably just about convince yourself there. But the right ventricular outflow tract crosses to go straight from AP towards the spine. I'll take off the color and try and find a different angle. So 4 chambers to left ventricular outflow tract here. We're looking for this continuity between the septum and the anterior wall of the aorta, the mitral valve, and the posterior wall. There's the LVOT heading towards the right shoulder. The RVOT is going more or less from front to back. Ascending aorta we see initially, and SVC over here. And if I can get out of the shadows, then we're going to come up towards where we see the transverse aortic arch here, the trachea, which is outside of the V, formed by the transverse aortic arch, and the ductal arch here. So there we've got SVC, aorta, RVOT, all lined up. And as you can see, in a sort of slightly ascending aorta with a PA and aorta of similar size, and then you head up and you can see the transverse aortic arch. You also nicely see another vessel here, which I'll put the color on just to show you because it's often a source of confusion, and it's heading down towards the right SVC, and that is the innominate or brachiocephalic vein, which is above the level of the 3-vessel view. So if you come in above that level, you will see that structure. Let's see if I can get another view taking away some of the shadows here. So LVOT shown nicely here. Usually we find these when we're not looking for them. LVOT nicely here. RVOT, front back, ascending aorta, SVC. When the spine is up, if I'm going to move to a spine up position, one of the things that you can see often really nicely is the left ventricular outflow tract. So if the spine is up, don't despair about the left ventricular outflow tract. You can actually see it reasonably nicely in here, even though the spine is relatively uppermost in this particular view. I'm going to try and find new views in here to overcome some of the shadowing. So again, I'm going back to the start, finding single rib, left stomach, descending aorta, we've got nice views of the ventricular septum here, which again is not part of the subject, but just it's showing up quite nicely here. Pulmonary veins coming into the back here. Just because we can see them, I'll show you them on the using the ADF. We need to take the scales down. And now you're seeing the pulmonary veins coming in at the back here, both on the left and then the right on the right-hand side. So you should be looking to see one on either side on color, using low velocity on the color scale to be seeing structures like the veins. We come up to the outflow tracts again. See if I can convince this baby to roll a little, but no luck at the moment. Now we're even more even more spine up. So I will again show you the LVOT is very nicely seen on the spine up view. And you just about, even under the shadows, catch the right ventricular outflow tract down in this type of projection here. But again, I'll see if I can convince you a little bit more about that. See if I can bring in the arch, not completely spine up, but now switching more into the true arch views. IVC, nicely seen coming through here. And higher scale for the arches. It's antegrade flow through both the ductal and the aortic arch. Now, if you're scanning and you're wondering which one is which, then embryologically, the superior arch is the aortic arch. So if the images are difficult and you're having to sort of make a judgment, then it's virtually always the case that the aortic arch will be superior to the ductal arch. Let me see if I can. Here we go. Try a different. See if we can do what we can do. We'll give it a try. There we go. This is spine up views again, but nice for the arches. So again, there are normal ranges for both the sagittal arch and for the ductal arch. So I'm switching here from the tightly wound aortic arch with the head and neck vessels, where there's you see the RVOT and the beginning of the PA arising much more anteriorly in here. So you've got the aortic arch here confirmed with color. I'll see if I can, again, give this baby a little nudge and see if we can get some movement. Okay, so LVOT, RVOT coming in here. Front, back. I'll see if we can convince you of that using the color as well. We've got branching as well there. So the RVOT in an AP projection, and you come up even further, and now you're seeing the transverse arch meeting the ductal arch. Transverse aortic arch, ductal arch. The ductal arch is more or less AP, catching some branching of the PA, early branching here, and upwards into the transverse aortic arch. Back down towards LVOT, so it's very much pattern recognition. 4 chambers, first vessel LVOT to the right shoulder, second vessel RVOT, which branches, third vessel forming the V in the upper part of the chest. If you're looking at things like, aberrant vessels, then clearly you can continue your sweep into the upper mediastinum to identify the branching patterns, aberrant subclavians, etc., etc.